For patients with acute myeloid leukemia, intensive induction and post-consolidation therapy usually requires prolonged hospitalization. We're at the ASH meeting on hematologic malignancies here in Chicago, and we're talking about consolidation chemo for AML done on an outpatient basis, specifically where specialty centers handle the post-consolidation chemo, but then supportive care is done using a shared care model with local centers that are much more convenient for the patient. So to talk about this, I am with a medical student, Samantha Hershenfeld, who is with the Princess Margaret Cancer Center in Ontario and their Cancer Institute there. Talk about the concept first, this shared care model.
So as you said, AML usually requires intensive induction and consolidation chemotherapy. And what our group and others have shown in the past is that you can actually deliver that consolidation care on an outpatient basis. But on the flip side, that also requires patients to travel often really long distances back and forth for frequent appointments at the hospital. And our center, Princess Margaret, has a very large catchment area, so patients can be traveling many hours just for their appointments. So what our center has recently developed is the shared care model. So basically the shared care model is you still get induction and consolidation at the Quaternary Care Center, Princess Margaret, but then your post-consolidation care, which includes biweekly blood count checks, transfusion support, and management of febrile neutropenia. So you can get that at your local centers. And in our model, there were 14 local hospitals in the province of Ontario that participated in our model.
And these are not hospitals that have been used to doing this?
So in every single one of these hospitals, there's a hematologist or oncologist who has some experience managing cytopenias and febrile neutropenia, but they don't deliver chemotherapy.
Okay, so that makes sense. So some of these centers, as you said, were quite some distance from the Princess Margaret Cancer Center.
Yes.
Now in your study, you actually mentioned, how far were these?
So the median distance from Princess Margaret was 70 kilometers, and that ranges. Some are very far, so multiple hours away.
So describe these patients and just how this process worked.
So the way the process works is when patients come to the hospitals, the nurses might identify certain patients who they see to be living distant from the hospital, and then they'll refer them to the shared care model, and they'll go out to their local center for their post-consolidation care. And what we found in terms of patient demographics is that this group was actually no different in age, gender, and cytogenetic prognosis to the patients who have all their care at Princess Margaret.
Well, that's pretty impressive. So how many patients were you evaluating in this study? And then you looked at safety and efficacy, I suppose.
Yes. So in the shared care model, there were 73 patients who were treated in that model from 2009 to 2013, which is the time frame we evaluated. And then we compared that to 344 patients who were getting all their care at Princess Margaret. So as you can see, it's still kind of in its infancy that there aren't quite as many people in the shared care model.
What you found was that it really works, correct?
Yes, so we wanted to quantify and confirm that they actually did save time and distance in travel, and both time and distance were significantly lower to the local care centers, as you might expect.
Right.
And what we also found, which is really significant, is that there was no difference in overall survival between those who received their care in the shared care model versus those who received all their care at Princess Margaret, the Quaternary Care Center.
I mean, now that there's some data to support this as it really works, do you think more patients will be offered this if they do live in the outer areas?
Yes, I do think that, and one would hope that it would systematically be offered to patients who are identified being very distant from hospital, that they have the option to cut down on their travel time and that burden on the family.
One final question, and you said there were 14 hospitals that were participating in this. Were they enthusiastic about this, or were they a little bit hesitant?
To be honest, I don't really have that information. I would assume they'd be enthusiastic to be able to treat patients in a way that improves their access to care and being able to get their care much closer to home.
But if they hadn't, I know in medicine sometimes if they haven't done something quite this way before, there's some hesitancy. So that was where I was coming from with that question.
Yes.
But I think it's a great idea, and obviously you're going to continue using this model?
Yes, that's the plan.
Anywhere else in Canada you would like to see this happen?
Yeah, well, now that we know that it's safe, at least for our center, it's encouraging to be able to potentially expand this in the future to other centers. And there have been reports across Canada, not too many, but of other centers having this sort of model, but it has never been evaluated. So that's why this research was so important.